Okay, so good afternoon and welcome to this second seminar of the series of newly appointed faculty member seminars organized by Humanitas University. These lectures are meant to give the opportunity to new members of the Academy to present themselves to the whole faculty and to the hospital. For those who do not know me, I'm Stefano Duga, and I'm the director, the head of the Department of Biomedical Sciences in Humanitas University. And I'm here today to present our speaker, who is Professor Alessandro Repici. The seminar will also be filmed, so students that cannot be here today because they are having a lesson will have the opportunity to see it on the Humanitas website. So let me spend just a few words to present our honorable speaker, Professor Alessandro Repici, who is here in Humanitas, the director of the Endoscopy Unit. He graduated in medicine and surgery in 1990 at the University of Messina and did his residency, if I understood well, across Torino and Messina in gastroenterology and digestive endoscopy. Subsequently, he worked in different hospitals and prestigious institutions abroad. In particular, he was a fellow at the American Hospital in Paris, and he worked also in the Altona Hospital in Hamburg, and also in Toronto at the Oncological and Operative Endoscopy of the Wellesley Hospital. His main fields of interest concern the development of new endoscopy techniques in the field of diagnosis and therapy, with particular attention to new methods of endoscopic removal of cancerous lesions. And he has a very good track of publication with more than 200 full papers in peer-reviewed journals and with a remarkable H index of 37. So I'm sorry because probably his presentation will be a little bit difficult for the videos that in some of these will not work, but I'm sure he will be able to present it as well. And so I'm pleased to invite Professor Repici to take the floor and to give his lecture, whose title is Today Endoscopy at the Frontier of Diagnosis and Treatment of Gastrointestinal Diseases.
Thank you, Professor Duga, dear colleagues. It's a great pleasure, it's an honor and privilege being here giving this lecture. It's a first lecture as a professor of gastroenterology. And I started doing endoscopy in the early 90s. I remember well the day I arrived in Torino from Sicily. It was very cold day, snowing a lot. This is a picture of the way we were doing endoscopy in December 90. And I immediately fall in love with endoscopy, so I recognized that discipline would have been the future of my practice. And I started my journey around the world, mostly doing a research fellowship. The only clinical fellowship I had was at Wellesley Hospital in Toronto, where I stayed for 6 months. It was a fantastic period of my life where I really learned what does it mean doing therapeutic endoscopy, especially in oncologic patients. So we started with a very old picture, and I learned in Toronto to work in international network, international environment. I truly understood how much was important trying to compare your practice with the practice of other colleagues, of other countries, of other hospitals. This is the group of clinical fellowship, of clinical fellows they here in Toronto. There were people from India, Australia, Malaysia, and China. So very, I will say, international group with some barrier in terms of language, but we were very close each other. We helped anytime each other. It was fantastic to work with these colleagues, and some of them still are very close friends of me. So we were with a very old picture. This is a frame that we just took yesterday. So yesterday we tried the first time in the world a prototype from Fujifilm, a colonoscope, This is a 3 millimeter colonic polyps. If you can see here, we can see the circulating cells inside the vessel. So this is something unique. I will show you again. You can see the circulating cells here. So for the first time, we are working with a scope that allows us to see in real time the cells inside the vessels into the polyps. This may be a big achievement because according to the vascular network and pattern, we can discriminate hyperplastic from neoplastic polyps. And the evolution of endoscopy was very strong over the last 5 years, and this is a first image of optical coherent tomography of the esophagus. We were part of a preliminary study with a new prototype, just trying to scan the different layers of the esophagus to distinguish from normal mucosa to neoplastic mucosa. And this data have been presented this year at the Digestive Disease Week. The endoscopy discipline has changed a lot in the last 25 years, especially because of the technological improvement. It is now the primary discipline for diagnosis and treatment of GI disease. It may combine detection, characterization of the lesion, and staging thanks to EUS, endoscopic ultrasonography. It's now the preeminent method of screening for colorectal tumors, for colorectal cancer. It remains the gold standard for large number of benign and malignant disease that can be treated only by endoscopy without any surgical intervention anymore. So there has been an evolution in terms of type of scope and instruments that we routinely use every day. We can reach now anatomical sites that were unachievable in the past, and we have a great ability in detecting lesions, in picking up lesions that were almost not visible in the past with the previous scopes. A typical example of anatomical sites that were not reachable until a couple of years ago is the evaluation of the small intestine. Now we have a dedicated very long scope like the double balloon enteroscope. We have the small pill cam, the small intestine pill cam that allow you to see just inside the small bowel, or you can reach the small bowel directly with the scope just in case the small pill cam has seen a target lesion that you want to treat by endoscopy. So we went a lot far away into the management of small intestine disease, and this is a typical example of a tiny lesion that you can recognize. There is no other diagnostic modality that can allow you to identify such a tiny lesion. There is no resonance, there is no CT scan, there is no imaging modality that can identify such a small lesion. And another big achievement with the evolution of the scopes for small intestine was that now, using a long scope with the double balloon technology, we are able to reach the papilla for biliopancreatic procedure in patients with surgically altered anatomy. So in this kind of patients with a regular scope, you cannot go until the opening of the papilla, until to the bile duct, the pancreatic duct, but just indeed because of the evolution of this long double balloon technology scope, now we are able to treat any kind of patients with biliopancreatic disease requiring endoscopic treatment, having such kind of scopes. The big diagnostic value of endoscopy is just to identify neoplastic lesion in their early phase of development. So this may come into the esophagus, into the stomach, into the colon, and also into the biliopancreatic system. So especially for colon, we have recognized colonoscopy as one of the medical procedures with the most profound and lasting impact on patients' life. This has been written because of the excellent results that have been achieved in the last 10 years with colonoscopy in preventing colorectal cancer. Everybody now is aware about the screening program on colorectal cancer, and we know that we can work against one of the most important killer, even in Europe, not only in the United States. We have one death every 3 minutes in Western countries, especially in Europe, but early detection can lead to up to 95% of long-term survival. So it's very important that people are aware about of the screening program, and they participate to the screening program, and they come for doing their test and their colonoscopy. This is a table showing, coming from a paper published a couple of years ago on New England Journal of Medicine. This was a very important study showing for the first time the protective effect of colonoscopy and adenoma removal of patients that did not undergo any colonoscopy. So for the first time, with a long-term follow-up study, the American colleagues were able to demonstrate that using colonoscopy and removing adenoma in patients between 50 and 75 years old, you can really prevent the advancement of colorectal cancer. Of course, the main goal of doing colonoscopy is try to identify such a tiny lesion. It looks very big, but it's not big indeed. It's maybe a couple of millimeters. So there is a lot of effort to try to develop the best technique, the best method to pick up as much as possible the colonic lesions during screening colonoscopy. And we have developed a number of quality indicators that are truly important to monitor what we are doing and to have a follow-up of our activities. We have introduced in Humanitas since a couple of months a permanent system of auditing of what we do in colonoscopy. We have a permanent recording of our outcomes, and this is very important because this allows us to understand if we are in the right direction. Now we have a benchmark for colonoscopy, including adenoma detection rates. It's very important that we keep this adenoma detection rate extremely high. And the adenoma detection rate is an independent predictor of the risk of interval colorectal cancer. It means that if we miss an adenoma, especially into the right colon, these patients may develop interval cancer, so a cancer in between two screening colonoscopies. And this is very important. This is why everybody is trying to understand how we can try to save the patients from the interval cancer in the right colon. This is a paper published in Gastroenterology from a Canadian cohort of patients that were treated with colonoscopy in the screening program. It was clearly demonstrated that there was no mortality reduction into the right colon. So we still have an area where we have to work more. We have to try to identify better technology or better way to scope the patients in order to identify the small lesion into the right colon. And this is a typical example of a lesion that you can miss. This video should start, I hope. So it looks everything normal, but this is not normal indeed. You will see in a couple of seconds that just applying a vital dye, a staining substance like the Malignant blue, you can recognize a very flat, we call invisible lesion. So if we miss this lesion into the right colon, this patient probably in 5 years will develop cancer. And of course, the report of colonoscopy will be, okay, everything is good. You can go home and see you in 5 years. Before 5 years, these patients will develop cancer. So there is a lot of effort to develop technique that can allow the endoscopist to have a better view, a clear view, and to identify the tiny lesion like the ones that I have shown before. This is another typical example. Here we are spraying Malignant blue with a special catheter. You see it looks everything normal. These are patients with ulcerative colitis. These are the patients followed by the team of Professor Danese. You see using special scope, you can recognize very early change into the mucosa, and very nicely you can see the opening of a colonic crypt. So technology that we have is now extremely good in looking to millimetric lesions, and we have to use this at our best to identify a lesion like this. You see the lesion? It came. This is a dysplastic lesion in long-term ulcerative colitis, and just using an optical zoom on the tip of the scope, we can see something which was not seen with the standard high-definition scope. Another attempt to identify more lesion is this new scope. Instead of having just one frontal view camera, this scope has 3 cameras. So 3 cameras to allow you to detect the lesion on the frontal view and on the lateral view. And this is very nice. It's been developed by a team in Israel, in Haifa, and now is marketed by an American company. You see, we can cover a much wider angle because we have a camera here, we have a camera here, and we have a camera here. And this scope has been used for a pivotal study that has been published in Lancet Oncology in 2014. And in this pivotal study, the authors were able to demonstrate the potential of this scope, having identified much more lesion than the standard colonoscopy. We have done, as an Italian team, we have coordinated the largest study until now on this scope, and we were not so good like the previous authors. So we randomized 800 FIT patients, so FIT positive patients with fecal blood test positive, and we randomized to FUSE or standard high definition endoscopy, and we were not able to demonstrate any advantage of the FUSE scope over the high definition scopes in terms of adenoma detection rate, detection of the lesion in the right colon, or detection of small diminutive polyps which are less than 5 millimeters. The study has been presented this year at DDW, is now almost accepted in GATT, so should come in a couple of months, and we are very proud that doing a study with a much better methodology as compared to the study published in Lancet Oncology, we were able to demonstrate that still this technology is not as good as has been presented in the past, and now we are working to the company to develop a second prototype of this scope to make sure that the results may be better. What we have developed all together with Silvio, I hope this video may start, is new frontiers developed here in Humanitas for delivering into the colon directly vital dye in order to stain the mucosa. When the mucosa is well stained with a contrast staining substance like the Malignant blue, this substance will allow you to see much better, to have a sort of image enhancement, a contrast enhancement, so you can see much better the small lesion. So this capsule has been enriched with Malignant blue and is taken during bowel prep by the patients. It is just arriving at the level of the right colon thanks to a pH-mediated mechanism that will start releasing the vital dye, so it will spray the vital dye into the colon, and this may be the results. The result is that we have a very reliable and very even diffusion of the Malignant blue along the colon. This is I'm sorry for the privacy, but this is column for Professor Malaysia. I'm sorry he's not here. He was one of the guys involved in the phase 2, and he was stained in a spectacular way. It was so good, so we could scope him very nicely and could recognize there were no lesions. Sorry about this. So we are increasing in terms of numbers. We are doing a lot of colonoscopy, a lot of colonoscopic procedure. And what we can say that early diagnosis, when we diagnose the lesion in the early stage, we can treat this lesion by endoscopic removal. Not because we don't want to refer to the surgical colleagues, but because endoscopic removal may have a number of advantages. And these are the type of treatment of early gastrointestinal cancer. It means intramucosal cancer. We have the support of the pathologist in diagnosing the level of infiltration of the cancer when we resect the lesion. And if you look here, only for the stomach, we have more lesions treated by surgery, but for colonic lesion and for esophageal lesion, we are almost equal in terms of number and volume to the surgical side. So when we say that endoscopy can remove early neoplastic lesion, we mean that we have new devices and new technology that allow surgical-like resection for cancer limited to the mucosa or the first layer of submucosa, and we try to have a scarless, organ-preserving, non-invasive resection to offer to these patients, especially patients with comorbidities, very old, that cannot be the best surgical candidates. So if we compare endoscopy versus surgery in this field, endoscopy is of course less invasive, has a shorter operative time, shorter hospital stay, it may have less complication rate, of course better quality of life because we are preserving the anatomy of the patients. It is definitely less expensive than any surgical operation. This is typically a lesion that we have resected at the level of the rectum. It was en-bloc resection in 2 hours of a huge lesion close to the anal verge. It took 2 hours. The patient was classified by Paula as an intramucosal cancer, so the patient was considered cured, is undergoing regular follow-up without any need for surgery. This is to show that we have resected first an entire esophageal mucosa in a circumferential manner. So the entire tubule of the esophagus was resected because of large superficial cancer. We did this endoscopically, and we were awarded as a best video this year at the DDW, but we cannot show you because otherwise the presentation doesn't run. Don't worry, don't worry. Okay, this is to show that we have worked a lot in resection of early lesion. We are the leading group in Europe. We are very proud about that. And this is results of a cooperative team, including the anesthesiologists, the surgeons. Anytime we have a complication, we have to work with the surgeons and the pathologists and the oncologists. We are very proud of this big team working every day all together in producing an excellent result for our patients. Of course, for doing such an advanced technique in endoscopy, you have to combine your work day by day with the surgeons. Sometimes we go in the operating room, sometimes they come to endoscopy room. We cannot do this without surgical support, and you can see there are techniques that give us the possibility to support the surgical resection, and sometimes the surgical side that is supporting the endoscopic resection. Another area where we have worked a lot is in building up the knowledge in treatment of patients with large bowel obstruction due to colorectal cancer. In this area, surgery for colonic obstruction in emergency setting is associated with a high rate of complication, morbidity, and permanent colonostomy. And this is the bridge that we are building up between the emergency presentation of colorectal obstruction, stenting of the patients, placing a stent through endoscopy, and giving the patients for the chance for elective surgery. And this was the first paper that we published, just demonstrating first time 13 years ago that after decompressing the colon with a metal stent, you can undergo safely to laparoscopic resection. And this was never proved before. So I have a number of videos about the new techniques that I will skip very shortly and going here. We are part of a strong international network for training and research. There are many people coming here every year, all together with Professor Malaysia, Professor Danese. We have a big event, which is Hunimed, and next year will be even bigger. This year we had more than 600 patients coming from 17 different countries. We are very proud about that. We always try to improve. It has been very difficult to develop all this network, but now we are in the network. We are having some leadership in this. Our Hunimed live endoscopy course is recognized as one of the best in Europe, and we will be keeping going, developing some more stuff. Now is the time of saying thanks. I have to say many thanks in this final part of the presentation. One thank is for Alberto Malesci. Professor Malesci was the guy who invited me to join Humanitas. I cannot forget this. And it was very helpful in supporting me, at least in the first years here. So I want to say thank to Alberto. The second thank is for Silvio. This is a wedding day for Silvio. I was very close to him, all together with Stefania. And I still remember when I saw the presentation from our president, Mr. Roca, said, if you have any brilliant researcher that you know abroad, please call him. It was 9 o'clock in the morning because we are developing the future. We are building the CCP, Humanitas Research Center. So I had the cell phone of Silvio. I met Silvio just twice in my life, no? So, but I had the cell phone. I called Silvio. Silvio was in Cleveland. I say, oh, what is wrong? It's 2 o'clock in the morning here. So it's very important. Send me a CV. He sent me a CV and the story started. It was very nice. He's joined this so strong in IBD, and it's very proud for me because every time I go everywhere in the world, this year I've been in all the continents doing live endoscopy procedure, everybody knows Silvio. So it's very nice for the institution, it's very nice for the GI team. And a big thank to the Humanitas Research Hospital and University, because this environment where to grow up, where to find your way, your position, your career. Of course, everybody recognizes it's very tough, it's challenging, but if you have a passion, if you have a commitment, you can take all the achievement that you deserve. This is very important. If you deserve something here, at the end you will achieve what you deserve and what you need for doing your job as a researcher, as a physician, as a professor. And these are the guys that are still working, so nobody could come because we said, okay, short program today, and I came in the hospital at 3 o'clock in the morning because one surgical colleague did a mistake saying that there was a huge bleeding. It was not bleeding. So I didn't come back home, but since this morning we have done more than 5 patients from the emergency room. So nobody from the endoscopy team could move here because we are very busy today, but they are part of the family. I spend more time with them than with my family, and I'm very grateful to all of them, nurses, physicians, everybody. And the last thing is, hopefully, okay. When I arrived here, I had only 3 kids. And I well remember the first day I came here, I went into the parking area. It was almost May or June. I counted at least 6 revertible Porsche. I said, oh, fantastic. This is the place where to work. I had a Lancia Y. I put the Lancia Y very far away from the Porsche because it says there may be a risk they can see me having a Lancia Y. But I just imagine that was the place where to work. I said to my wife, okay, we can grow in the family. Probably I have a new position. So from 3, we went to 4. Now they are like this, very terrible. And of course, these are the most important part of my life because I do not deserve staying so far from them, but anybody here has a lot of commitment. We have to work a lot. We have to fly a lot. I can say that I fly on a regular basis every week now. And I miss all of them, of course. It's very important. And finally, the last thing for my wife.